So good afternoon, everyone. Thank you for joining us again on another Journal Club. We're very excited today to be talking about addressing the public health challenges. And as usual, we're going to start by going through a state of the state. So I want to start first with some global numbers. And we're over 18 million cases worldwide, with the United States, as we all know, in the lead. If we go to the next slide, we find that in the US, we're over 4.7 million cases. I believe this number on Worldometer is actually trending higher. When we look into those numbers, the average daily positivity rate for the United States is at 7.13%. And that really, brings us into conflict with what the World Health Organization has stated about when you should reopen the country. We know we're in the midst of all of those decisions, not to get into any of the politics of it, but I wanted to just show you something else from the Johns Hopkins Coronavirus Resource Center. If you go to the next slide, as we stated last week when we were looking at trends, this slide I found very helpful because it lets you know where your state lies as far as positivity rates, and looking at the guidance that the World Health Organization put out. Currently, 37 states are higher than the recommended positivity rate for reopening, which, as I said, is 5%. If we go to the next slide, just to take a look at what is happening in Florida. As of 11 a.m., this was updated, and we're at over 497,000 cases. In the past few days, we saw that some of our testing centers were closed because of the anticipated tropical storm, then hurricane. And we know that our numbers for testing are actually have been lower because of those shutdowns. So I'm anticipating these numbers to go up over the next couple of days. Currently, this means that our positivity rate is at 18.2%. And like I said, it's trending higher. I also wanted to show you the update from the facilities being tested. We saw that as far as this morning, August 5th, the positivity rate in the facilities were 4.03%. And when we look at the staff, that positivity rate is 2.87%. So we do know that our state is one in that, that under the guidance of CMS, we will have to be testing on a every week basis for our staff. So in looking at that and in thinking about where we're at and how far we've come and how far we haven't come, I really wanted to sit down with a population health expert and have a discussion about where we need to go. And if you go to the next slide for me, that brings us to having this discussion with Dr. Cannone, who is joining us here from his car office, which I love. And we're going to discuss public health challenges, and I will let Dr. Cannone introduce himself.
I wanted to make sure I was in an environment where I didn't have to wear my mask, so apologize for the makeshift office here, but no, thank you, Diane, for having me, and to Ian as well. I'm a long-term care, post-acute care geriatrician at heart, and been doing that for 20 years, and been kind of thrust into some really interesting aspects of the COVID pandemic just because of my role at university hospitals. So I'm happy to be here today. I appreciate the opportunity. I've been a member of FMDA in the past and had the opportunity to be there to speak at some of the conferences, and just always a pleasure to be with you.
Yes, thank you so much. I want to start by just asking you to describe Ohio's COVID response, if you would, at a high level, and maybe we can then go into some details about how we address the needs of the nursing facilities and the assisted living facilities, and even the testing strategy that you guys have.
Yeah, so maybe just by way of kind of a running start, I was diverted off my long-term care, post-acute care practice, clinical practice, medical director track back in about 2015, and ended up with a population health company in Dallas, Texas, and had put together a really interesting patient-centric, site-agnostic population health model that could deliver basically any needed good or service or person to a patient within an hour potentially. And we actually had a statewide contract with Florida Blue, 100,000 lives, and stood it up in 60 days and had a really great success there. And so when our parent company went through a merger and our population health division was dissolved, a lot of us recongregated. A lot of us were from Northeast Ohio, recongregated here at university hospitals. But that experience, I think, has reshaped a lot of the way I think about managing population level care. I hadn't really thought in those terms in the past. I had thought of my facility as a population, but I think some of what we've been able to do here during the pandemic, it was really kind of a meshing of my knowledge and experience and history in long-term care settings, which has been incredibly valuable, and this population health background. So my role here at UH is heading up our post-acute quality networks. We have 60 nursing homes, 3 acute rehab units, a couple LTACs, 600,000 ACO lives, and I head up as a medical director our home care division, and head up our joint venture with our hospice here in Northeast Ohio. So it's kind of putting all those pieces together again and trying to figure out how to do that outside of the hospital walls and interfacing these different congregate settings, and with 12 now regional hospitals is kind of a new thing for me. University hospitals and Cleveland Clinic are kind of the 2 big systems in Northeast Ohio. And so it's been really interesting. Traditionally, the 2 systems kind of fight one another, not necessarily openly, but there's always kind of a game of one-upsmanship trying to be played, and they're the 2 big competing entities in this area. And so when the pandemic started, I was kind of the default person for UH, really the one who was interfacing already with these congregate sites outside of the hospitals, and kind of thrust into this role of leading our attack for those settings. And that's kind of where it all began. It's I don't know if if you want to kind of go through the story. It's been crazy for me, because I'm not really a public health type person. I think many of you probably come from a similar long-term care, post-acute care background, and a lot of times we kind of see the state and health departments as more adversarial and not very helpful in a lot of ways, and there's a lot of fear in those relationships, and all of a sudden we're put into a pandemic where you have to all of a sudden make friends with a lot of people and learn to work together collaboratively. And so that's kind of the background on where I'm at.
Yeah, so tell us, I'm very curious, how do you, with that background, go into the Department of Health and lead the strategy? Really be the voice and advocate for the healthcare systems? Yeah,
it really was a backdoor approach for me. It's been very interesting kind of watching it all play out. So, early on in the pandemic, we had two nursing homes that were very close to one of our hospitals. And so a lot of this began really with these 2 facilities having a major outbreak. And I don't know what the experiences have been of others here, but those first 8 or 10 weeks or so were pretty devastating. I mean, we were having it seemed like even a much higher virulence, much higher mortality rates, obviously a lot of fear. And we had been working for about 3 weeks prior to the pandemic, me and a couple of colleagues at UH, trying to think of, based on what we saw out on the West Coast, what are we going to do? And it kind of came down to really a strategy to do several things. One was really to look at isolation centers. were there partners in our community, specifically nursing homes, who might be willing to take COVID positive patients, knowing that our hospitals were going to surge, or that was the expectation, and that we would need to have some way to throughput to maintain some capacity in those beds to be able to care for people who had need. And so we started to look for places who might be willing to partner, and it was extremely difficult at that time. We had 2 or 3 that stepped forward. Most of them were 1-star facilities with a lot of empty beds for obvious reasons, and we're kind of, not sure this was going to be the best scenario, but we needed some help. So we began to kind of develop relationships there. We developed a connection with Massimo, which is an electronic a telemonitoring platform. We started to institute in some of our hospitals to expand our monitoring capabilities in our isolation units at the hospitals. We implemented that in several nursing homes, and with our home care division as well for home use. Very interesting platform. We then put together a transfer tool. I mean, it became evident to me that the movement of people back and forth between whatever setting, hospital to home care to hospital, SNF to hospital, hospital to SNF, there was going to have to be very good communication around, what's going on with this person. What's their symptomatology? Are they known COVID? Are they not? And this is very early in the pandemic, so we put together a transfer communication tool and kind of mandated its use throughout our quality network, just to make sure we were communicating and handing people off safely. Knowing that as we met with EMS and some of the local fire departments, that there was concern, and with our EDs as well, that we didn't want to expose people unnecessarily, and we wanted to make sure they were prepared to handle people with the virus, or with presumption of the virus. And really the third thing that we did then was put together what became affectionately known as our playbook, and I'd be happy to share that with you, offline if anybody has interest. But it's an ever-changing document, and really what the playbook was a pre-planning and outbreak management guide, specifically geared toward nursing homes. And our playbook was really just me and a colleague pulling together CDC, CMS, Ohio Department of Health, NIH, guidance to try to figure out what to do. We had to get educated really quick, just like everybody else. How do we handle people? How do we cohort? How do we test? What are the strategies? And so that started to morph then into a best practices, and we began to kind of give it a little bit more of a UH flavor. How to interface with hospitals, how to transfer patients, and came up with what we call a 7 pillars model, where with these 7 strategies that kind of support this kind of COVID outbreak and pre-planning management strategy. And they were team building, transmission reduction, triage preparedness, lots of T's, targeted conversations, telehealth capabilities, testing and treating in place, and transitions of care. So we felt like those 7 areas really covered the majority of what we needed to get facilities at least somewhat prepared for what was coming. And it gave us kind of something to rally around as a point that we could kind of agree upon. And, from the team building aspect, to go back to your question, it became very evident we had to link arms with, it was called kind of a tripod approach, really, which was public health, the facility leadership, and then our local hospital partner, our health system. And those 3 had to be very finely in tune with one another to manage what was going on. And we had to, I'll just kind of give you a background on how this played out for us, and then I'll pause here for a minute. But we had these 2 facilities that really caught on fire too quickly for us to really pre-plan. One was in our quality network, one was not. It really didn't matter at that point, because being on the hospital side of things and being the interface between the 2, not only did I need to come up with a solution to help support this facility in place, but I also needed to find a way to have our hospital aware of what was going to be going on from a surge standpoint, and to have local EMS and fire kind of aware of the situation, to develop strategies for direct admissions to try to reduce exposure and preserve PPE, and to prepare that way. And by the time the third outbreak happened, it was in a county about an hour east of us, but we had a local hospital there. And this one of our team members had kind of lived in that community and literally took our playbook, which had just kind of come fresh off the press, and ran into this building. He's a fireman by background, and now an acute care nurse practitioner who helped stand up the critical care transport for Cleveland Clinic, and kind of went in and said, let's just sit down. This place was an absolute disaster when he walked in. And there's a video that we're putting together. There's about a 4-minute version that has been completed that I may be able to share with you at some point if you're interested. And then there's a 20-minute version that's a little bit longer that tells the story. But absolutely, I'm sure many of you have encountered the same situation. It's just devastated nursing home, not knowing really what to do. And we were able to guide them through this. Using the playbook, it kind of brought some calm. Stepping into the situation, we supported with staff, we supported with PPE, we supported with testing, and got all this stuff kind of put in place, looped in public health, had a very close relationship with them, and it really worked out so well, although their outbreak was devastating. I think they ended up with 30 plus deaths, and it was really rough. But in the end, it caught the attention of the state of Ohio, and they wanted to hear a little bit more about what we were calling our Intercept program. And we'd put a team together of 2 physicians, myself with a lot of long-term care expertise, another physician with emergency medicine background and epidemiological training. We had 4 acute care nurse practitioners, 2 medics who work on our EMS disaster division, and then we have a licensed nursing home administrator to help interface with the facilities, and then another person who has deep experience in resident and family advocacy. So kind of had that whole patient experience and rights thing in mind, which has been very important through the pandemic. And so that kind of really started another journey. While we were busy doing all of these things in these congregate settings, it kind of pushed me right up into the governor's office and working with the head of Ohio Department of Health and Director Corcoran, who's our director of Medicaid, who is tasked with kind of overseeing the COVID management for nursing homes in Ohio and all congregate settings. And before we knew it, I think we're up to almost 200 facilities that we've intercepted. They range from nursing homes to group homes to a lot of correctional facilities, assisted living facilities, senior living communities. And while everything we do in the playbook doesn't apply to all those settings, I think that the basic philosophy is held. And it's really, it really, to me, this pandemic has taught me that it's really more about relationships and trust, that even as much or maybe more so than the resources. I mean, resources are scarce at times. Testing has been a real challenge for us. PPE has been a challenge, staffing's been a challenge, but I think the relationships that we've built have been very valuable.
Yeah, I would definitely say. Before we go on, can you repeat the 7 T's, the 7 pillars? We've got a lot of people.
Yeah, so, and I could share this later, but so team building was the first one. And it really, and this is more pre-planning. This was about getting facilities, do you know who your local health commissioner is, or have we developed that relationship to where you kind of know they're part of this team? And obviously the team at the nursing home, the medical director is so important here. I can't state enough how the situations that have gone the best, even though the outbreaks have been horrible, where they've had strong medical director leadership, it's just been like night and day. And obviously then the team, consisting of, a hospital partner as well. And the second is transmission reduction. So these are just basic things around what are you doing to screen people, to monitor? How do you utilize PPE? We're still finding that it's an ongoing need for kind of education and oversight in terms of PPE utilization. It's very easy to get fatigued in this pandemic and let our guards down. And that's been something that's very important. Triage preparedness is number 3. And this is really a component in pre-planning around, what do you do when you have your COVID index case? What are the steps? And how have you set up your building to be ready to isolate, to quarantine? And those facilities who really took that step seriously and tried to stop, new admissions, tried to get some of the more stable folks into a home setting with families who are off work and get home care involved, and try to decant sections of the building to be ready and have that isolation unit set up, have done better. The ones who really have not and have been reactive that way have been a real nightmare for us, for public health, and for the hospitals to really to support, because they just don't have a plan. And triage preparedness also goes back to, what do you do with testing results? It's so frustrating to see that testing gets done without really any plan for what you're going to do when the results hit. Not notifying, and patients just start crashing the doors, and staff members start crashing the doors of the ED. We've really tried to get ahead of that. The 4th is targeted conversations, and that really is around end-of-life care. We looped in our palliative care experts at UH to develop some resources early on to talk about code status, advanced care planning, to kind of prioritize those things with families. There were a lot of families who honestly were willing to have those conversations that hadn't in the past, because they realized how significant this could be, and they didn't necessarily want people, their loved ones, in the hospital. So that's been a very good thing. And telehealth capabilities, obviously, I think you've all experienced the same. I mean, when you can't get in as a provider, we've actually now in Ohio, I know for university hospitals, our ICU utilization is very high right now, but it's a very actually small number. I think it's around 10 to 12% are COVID related. The rest are patients who have really gone the last 4 or 5 months without the care that they really needed. They couldn't get in for surgery, get into office appointments. There was no good means for virtual capabilities, and not only for nursing homes, but those living in the community. And now they're suffering the consequences of that. So telehealth in these places where we had high risk populations that really needed clinical care, but you just physically couldn't get access. The 6th is testing and treating in place. So it really goes into a little bit of testing philosophy, which has changed over time. And a lot of it is really geared on what we have available. Right now, UH and Cleveland Clinic have the majority of the testing capacity in all of the Zone 1, which is the northern half of Ohio. I serve as a clinical lead for Zone 1 for Ohio, and it's been really difficult the last 2-3 months to have to say no to a lot of places that really need testing, because we just don't have it. We don't have a reagent to sustain the capacity, and we sometimes don't have the skilled technicians to run the PCR testing in other situations. And then I think treating in place has definitely changed over time. Early on, I think there was a lot of hydroxychloroquine utilization. Now that's kind of fallen out of favor. There's some remdesivir that's available in certain situations, but a lot of this obviously is just symptomatic management at the bedside. And thankfully, I'll knock on leather, that it seems that the clinical presentation, the expression of the virus has changed a bit since those first 2 months, and there's a lot of hypotheses as to why, and hopefully it stays that way. But and then the final is transitions of care, which is really all about how to move patients safely, how to recover patients out of isolation, even back to the general population, but also how to move between healthcare institutions and facilities safely. For us at UH, it was developing a transfer center with a direct admission protocol and trying to get people to be able to bypass a lot of touch points along the way. We actually had in that facility in Geauga County, I mentioned, it's the first, to my knowledge, I've ever experienced in my career. We had a patient go from long-term residential nursing home, direct admission to ICU bed, and to ventilator pretty quickly.
Wow.
So that was pretty incredible to be able to bypass a whole bunch of steps along the way and kind of do that in a very efficient way. Those are the 7 pillars.
And I mean, it's really impressive. Even the way you lay it out. Florida being Florida, and some of the other states I think that we have represented on the call may attest to the same thing, where we find it hard, I would say, to manage conflicts. And this is a question that actually is also in the chat. How did you develop that trust between those competing interests, as you said before? Hospital system against hospital system, nursing facilities against nursing facilities, even the Department of Health. How did you all come into a consensus in Ohio?
Yeah, I have to say a lot of it was driven by the governor's office and by Director Corcoran. I think that they've been very effective in the way they've led throughout this. And I have to say it's been so interesting to see that, every county obviously has a different public health entity, and sometimes it's a city, sometimes it's the county itself. And that's been very challenging. We have different relationships with every public health in every county that we're in. We're in nearly 20 counties with our 12 hospitals. And so that's been challenging. Having been pushed kind of to the forefront as far as a zone 1, we call it, clinical leader, I was teamed up with a physician, ID physician at Cleveland Clinic. Her name is Dr. Alice Kim, and she's been absolutely fantastic. And I think there's been so much collaboration between UH and Cleveland Clinic over the past 5-6 months that there's actually now discussions about even moving forward, if we ever get out of this pandemic, that it really does make a lot more sense for the communities that we serve to partner in ways that we never have before. And I think it really, and unfortunately, maybe took something like this where no one could handle it on their own. Public health was coming to us and begging for support because they didn't have any more testing, and they didn't have enough people to do contact tracing. They didn't have enough resources to even get into the nursing homes to help train on infection control practices or guiding cohorting strategies. So it was kind of like all hands on deck. And I think it forced us to develop a lot of trust between these entities. And for the nursing homes themselves, it's been very interesting. Obviously, I think early on there was and we still see this to some extent, there was a desire to kind of fly under the radar and really not have anyone knowing what you're doing. You didn't want anybody to know that there was testing going on or maybe an outbreak occurring. And that didn't last very long because those places imploded very quickly when they didn't have support. And I think a lot of them realized, you know what, this is not something you can do on your own. You can't fly under the radar. We're going to need help. We're going to need local emergency management. We're going to need a hospital system. We're going to need our other skilled nursing facilities in the area to help take on some of the burden. And then, expanding from there, I think, the huge challenge has been assisted living and group homes over the last 2.5 months, because there's just not enough clinical infrastructure to support, and public health, which had kind of taken ownership of those and handed off the nursing home responsibility to us, just ran out of capacity for those environments as well. So it's been challenging. I can't really give you a simple explanation as to how it worked. It's just, I think it was just, you're kind of forced to do it.
No, I don't think I would expect a simple explanation given what we are seeing here. And we are with FMDA, we're with this organization and trying to even express our opinions. It's challenging because you don't know who is receiving that information. I would say that our members are always communicating back to us and telling us the challenges that they're having. And when it comes to ALs, there's a lot of the assisted living facilities, there's so much variability between what each of them are doing. I'm just curious to know for you, how are you testing in the facility in the ALs, and how quickly are you getting those tests back? Has there been any isolation unit, like maybe a patient going from the AL to one of the nursing facility units? I'm just curious to know what you guys are doing.
Yeah, so testing has been a huge blessing. I don't know how I would have done my job, honestly. There are so many hospital systems around us that have zero testing capacity. And Cleveland Clinic had quite a bit. So my role has been to try to manage that finite resource across a really broad geography and set up an entire platform for how that happens, from the point of contracting with these entities, because we've got to have certain things like an ordering physician and, ward numbers for billing appropriately, and, fax numbers for reporting results, and all of these things. There's a lot of front end work that goes into that. And then there's, probably the piece that forced the relationship with me in particular, and with our hospital systems and zone leadership, was that the facilities didn't have anywhere else to go for testing. There just weren't other options available. So it gave us the ability to develop these relationships early on, and then we couldn't just give them unlimited resources. So, we really had to be involved in their decision-making process around what's going on today. They were, they're giving us daily sit rep reports. And so we're in real time could say, here's what's going on. Here's how we should address this. And maybe it was testing the whole facility, and we could pull that off if we needed to. Other times it was, let's do a smaller cohort of testing. And some of it was me balancing things on the back end, trying to figure out if we had enough capacity to run them on any given day of the week. But it forced the facilities to come to us and say, we think we have a problem. Can you help? And that's really been a good thing. The testing we do, we have 6 or 7 different platforms we run PCR testing on right now. And, I think we're doing, it's several thousand tests a day that we have capability to do. As far as the testing that's been required of nursing homes from the CMS mandate, none of the labs had capacity to keep up with that kind of demand for capacity. So we help the state coordinate through our Ohio National Guard the testing of all staff members in nursing homes for a baseline testing, and we're going to be going through more rounds of that now. But they were using an outside lab to do that, and we were having some significant problems with delays upwards of 10, 12 days on results, which make those tests essentially worthless. I've said all along to our partners that, PCR testing was never created for the way we're using it today for these large scale screenings. PCR testing is just not, it's not a good test for that kind of thing. It takes time to run the test. There is turnaround time. Ours have been typically between 24 and 36 hours, which has been pretty good. But, a positive tells you absolutely nothing about a patient's infectiousness, and a negative tells you absolutely nothing about what the patient's status is going to be tomorrow. So you get a very limited amount of benefit from that testing. And as far as the isolation center thing goes, we did work with the state. This is one area they've really helped us. So they put into place at the level of our state Medicaid and Department of Health a process for facilities to apply to be healthcare isolation centers, HCICs. And they can be an isolation unit where they can take positive patients, a quarantine where they'll take PUIs, persons under investigation, or a combination IQ where they could take both. And we've been very successful. Myself and Dr. Kim head up that strategy for Zone 1. We take all the applications, do the approvals, hand them off to Ohio Department of Health for their approval. And we have, I think, 8 or 9 that are up and running today. And to answer your question, yes, our first real bad situation from an assisted living came. It's been a couple months back now, but it was a very small one, thankfully. It was 16 beds, and 8 of the patients tested positive. Nobody knew that they were doing testing. They were getting some testing from their county health department, county health department was really, actually in this particular county, very territorial and didn't really want to engage the local health system at all with like kind of this coalition strategy. And it kind of came back to bite everybody on a Friday night at 7 o'clock when half the residents showed up at our local emergency department and the staff left. There was the owner, his daughter, and his wife left to try to care for the other 8 residents, and they were going at 24 hours at that point. And within a matter of about 2 hours, we had our entire Ohio strike team on the call, which includes the governor's office, state ombudsman, the county EMA, county health department, local health systems. I mean, everybody, it was amazing how many people got pulled together on this particular call. Transportation, EMS. We had every one of those 16 people, including the ones that were at the hospital, placed in 3 of our healthcare isolation centers. One of them was an hour away, so it took a little bit of doing from a transportation standpoint, but they all were placed by the next afternoon. And that facility was able then to disinfect, to heal their staff, and to come back online. It was several weeks later, and then kind of pull some of those folks back to them. But we've had that scenario now several times. Last week we had another where it came up, but so that's been the strategy here, and we're looking to add more healthcare isolation center beds. They have a higher reimbursement rate from our Medicaid for taking on that role, which is to kind of help with PPE and staff costs.
Yeah. So we had another question from our chat about Department of Health enforcement activities, really around infection control for the SNFs.
Yeah.
Have you seen any of that where facilities are getting in trouble or being receiving tags for having outbreaks?
Yeah, it's they all went through their ICAR surveys, and early on we had it really kind of came to a head because the state was so pushing our intercept strategy and trying to replicate it elsewhere around the state, that there were a couple facilities that had immediate jeopardy citations and fairly large fines early on, and actually 2 of them were facilities where we had one was direct involvement, one was peripheral involvement in another zone. And we pushed really hard with the state at that point to kind of understand what the citation was about, and and to remind them that we're donating a lot of time and a lot of resources and a lot of services to helping the state and county health departments do what is probably honestly their job, but they're overwhelmed. And we're happy to do it. It's been a real honor, but we want a seat at the table when it comes to thinking through these citations. I mean, we want them to be constructive. We want them to be fair. And if a facility is going to come and say, we did exactly what university hospitals told us to do, or what the Zone 1 clinical leadership told us to do, and now we're getting cited, it puts us in a really awkward position. So in those particular cases, they were willing to share some of the details of the citations, and it really wasn't related to things that we had engaged them on. There were some legitimate concerns, but from that point forward, I don't know that I heard of any other immediate jeopardy. So I think the word got through to them that we really needed to be more constructive in these ICAR surveys, and give us a chance to step in and to support and to train and to educate and to monitor before we kind of just get too punitive, because the risk here is that it just won't be helpful going forward to be that punitive, and there's a risk that these places are teetering on the edge at times financially, and we can't really at this point afford to have a 150 bed nursing home go under, or to decant completely. We've had that happen once here already, where it was just they'd had enough, and it was a fairly large facility. They just basically shut the doors and decanted the facility, and it was challenging. So we want to be more supportive rather than punitive in what we're doing.
So I have, going back to a couple of points that you made, you mentioned the variability between county to county. And I think we being here on the ground in Florida, we've definitely seen that. I'm also interested in knowing how you develop the strategy, given that variability, and given the fact that Ohio has some urban areas and some rural areas, and I can imagine, as you mentioned before, distance and the challenges there. So how did you address that in thinking about those issues of the location of the population, as well as all the healthcare disparities that may exist between the urban population who may have a different demographics than the rural population?
Yeah, so I think, from the urban standpoint, most our largest hospitals sit in urban centers and in Cuyahoga County primarily, and a lot of that was testing support. So that was, our public health has been phenomenal in Cuyahoga County. They're very, very robust public health. Both Cleveland itself, Cleveland County, or Cleveland City Public Health, and Cuyahoga County Public Health. And so, they're very, very active in terms of the screening and contact tracing and swabbing. They just needed back-end support with laboratory. So, we were able to step up with Cleveland Clinic and with Metro to kind of help support in that way. We did lend our Intercept team to quite a few of those settings, and some of those were different for us. To go into a senior high-rise, urban high-rise is very different, than a clinical setting. And so I can't say that was our forte, but a lot of it was just helping with education, making sure that they had masks, basic kind of infection control practices, and then looping them in with hospital resources where we could. That's the nice thing about being a part of a large hospital system. One of the things that we were able to do to really help public health and identify need is we have a whole kind of logistics and analytics arm to UH that actually comes from the backbone of the company and the population health company in Dallas that we were with, that has been actually, we've been pooling data with Cleveland Clinic and with all the local EMS in Northeast Ohio and EDs, and have developed a hot spotting map where we can see everything in real time. Test results, we can see within, even down to the level of an individual in a house where they live, and then out from there in a community where we might see a hotspot developing. We can see EMS runs from a particular community or to particular hospitals. And so that's been very helpful at allowing our team and public health to be more proactive and know where to kind of shift resources to more rapidly. In the more rural settings, I have to say that from my role, it's really been more agnostic to the setting itself. I mean, we've been in youth detention centers providing testing. It really has been just the next call. Who's the next call? Who has a need? Where is there an urgent issue? How do we leverage our capabilities and our resources to help? And as soon as that one's under control, it's the next one. And they were coming, I mean, like I said, upwards of 200 now over 4.5, 5 months. So it's, almost at 1 or 2 a day for a while there, 3 a day, where we were trying to deploy resources. There wasn't much time to think, well, is this urban or is this rural? And is this, it was just trying to be helpful to whoever raised their hand and needed help, honestly. But now that we're kind of, in this phase where there's more community outbreak, the attention definitely has shifted more toward settings where there are lower healthcare resources available, and especially in the urban settings. And with I had the honor of, I've had a lot of honors throughout this whole process, but I got to meet with Simi Verma here about a week and a half ago. She came into UH to meet with our Rainbow Babies and Children's Hospital leadership to kind of hear about some of the strategies that we were implementing for pediatrics and youth within Cuyahoga County, which is really high poverty rate. And that was fascinating for me to hear, because I wasn't even aware of what our organization is doing in those settings. I was really impressed with what they were doing. And then SEMA has a lot of passion for nursing homes. And so we got to talk quite a bit about what we're doing with our Intercept program. And it was interesting because she said, they've been wanting to, and they're looking to create some kind of, they're calling it a strike team. We call it intercept, at more of a federal level, and kind of structure that in a way that can be reproduced elsewhere. And so it's been really good kind of following up from that meeting and sharing some of what we've been doing with them at the federal level. And then got a chance to talk with Dr. Burks here about a week ago. She was on a call with the governor's office and got invited to that meeting to kind of, it's just been very, very interesting and very honoring to kind of, for those types of things. And then I saw your Johns Hopkins information earlier. One of my colleagues at UH has a lot of deep roots at Johns Hopkins, and one of his colleagues had gone on to the World Health Organization and was heading up some of the strategy for congregate settings, nursing homes around the world. I got pulled into that over the last couple of months, and they just released their policy brief. So that's been interesting. I don't know that it applies in a lot of ways to what our discussion today, but it's amazing how a little nursing home doc, when put in the wrong position at the wrong time, I guess, you just kind of I end up looking back on this now, and it's like, this has just been a whirlwind of craziness.
Oh, I think it's amazing, and we did have a question about your involvement with the World Health Organization. I mean, just in thinking on the need for advocacy, I'm just so happy to not only have met you, but just to hear everything that you're doing, and the work that you're doing, not only in Ohio, but for everyone.
Yeah, and I have just a fantastic team. I can't speak highly enough of them. I have to be honest with you. I was pretty content to be at home orchestrating and administrating all of this. I think that's a sweet spot for me. I was not too thrilled to be running into COVID positive nursing homes. To be honest with you, I have 4 kids, and I don't know. I mean, it's just part of human nature, some fear. But my team has been absolutely incredible. I mean, to just run into these places where everybody's running out, and to sit there and help them work through. And I'll tell you what, to see that through and to get the email, just wanted to let you know that we just moved our last patient off of isolation and we're in recovery. We're full, has been one of the most meaningful things I think of my entire career. It's strange, but I'm just so proud of my team and the work that they've done. There really is no intercept program without, someone being willing to kind of run into those situations and just walk through it with people.
I thank you, Sean, for everything that you have, you're doing, and everything that you've shared. And I'm going to ask our participants if they have any other questions for you, because you share so much. It's been incredible. But if you have any questions, please put them in the chat while we still have Dr. Cannone here on the call.
And yeah, while we're waiting, I just appreciate the opportunity to be here. Every one of these calls that I'm on, meetings that I'm in, I'm really looking to learn something and to grow a bit. And I would just think, we were saying before the call started, I don't think we're out of the woods on this yet. It's going to be a very interesting fall and winter. And so I would definitely like to keep in touch and continue to learn from what you're all experiencing, especially in Florida. I mean, it's just definitely in our thoughts and prayers, and it's just a difficult time.
It really is. And we're where I sit with in the organization I'm with, we're trying to figure out our flu strategy, how to meet that challenge given this current pandemic and what we need to do. And it really makes me wonder about the infrastructure of post-acute long-term care, where we need to go, how we need to adapt and change. Yeah.
That is a fantastic point, and it's been on the front of my mind the last couple of weeks or so, that you can kind of envision what the world may look like in the future. And I think that AMDA and the state chapters of AMDA need to be on the forefront of driving that thought. Even down to the point now where I wonder if there's, if we can even operate without having an isolation unit that's there. I mean, you think about what we've encountered with influenza and other things in the past that are problematic as well. Maybe not to this scale and scope, but it makes you wonder, like, how we've been doing it all along. There probably are better ways to do this.
Yeah, I totally agree. I think Ian and I were talking about this the other day. What does the future look like? You're going to have to be prepared at a minute, in a moment's notice, to go into COVID prep. I'm just really curious. We did get a question in the chat about the supportive treatments that you mentioned. In your playbook, do you have any protocols or anything, that guidance that you gave to your facilities around supportive symptom management?
Yeah, a lot of it's just very basic around hydration and oxygen support, but there's been a lot less respiratory compromise than what we saw early on. So there's been so much asymptomatic, which has made this very difficult actually to control, because it's so hard to know. And I'm thankful for that. But yeah, early on we had taken, CDC had some very clear guidance on the use of hydroxychloroquine and azithromycin. So we had those dosing regimens in the playbook early on. Even after they took them down, I think a lot of people were wanting to use it in certain circumstances, and there was an allowance for it, but there was really no good, we still wanted to be able to educate what do the dosing strategies even look like, so we don't use this incorrectly. Now that that's been pulled down and there's not much support there, we've taken that out. So that section, I have to say, is probably the most bland. There are not many ways to treat this other than being very supportive. I would say that, if a patient's a full code, or if you think that they're declining in status and heading toward hospital, we've been very encouraging of facilities to start that process earlier and get them moved while they're still relatively stable, rather than waiting till they're crashing. But outside of that, yeah, it's very, very generic, I would say.
Any other questions for Dr. Cannone? Well, I thank you for your time and for joining us from your car office, and I hope your son does well in his tournament.
He had a rough front nine, so I think it's going to be a long ride home.
Thank you, and thanks to everyone who participated today. Thank you very much.
I appreciate it, Diane. Thank you very much.